Good afternoon. My name is Ed Llewellyn. I work for the Global Financing Facility, which is part of the World Bank. We are constituted to raise money for and support access to reproductive, maternal, child health and nutrition. And we do that by co-funding alongside the World Bank. So our relationship with countries piggybacks on that World Bank arrangement. We fund directly into government in order to, as I said, to improve access. I'm delighted to be joined by an erstwhile panel. You can see the names on the slide. I'll introduce them again in a moment as we go through. But in terms of framing this session, as I said, working on RMNCHN, some of you will be familiar and happy with that acronym, there is a recognition that distinct from some other programming areas like HIV, TB, malaria, etc., there is already de facto a very much mixed system for delivery of those commodities to people. What I mean by a mixed system is both public and private sector operating often in parallel to make sure that those commodities reach people. If you're looking at a mixed system, then the role of the GFF, as we see it, and we're developing our strategy for this in commodities supply chain, is to make sure that those mixed systems are designed, if you like, from the patient backwards, that they are patient-centric, and also that we, in funding in the way that I described, are supporting governments with their obligation as stewards of that mixed system. That brings with it challenges, and the key challenge is integrating the way in which those two different systems work together. And today, I'm going to ask the panelists to describe what I believe are not necessarily the whole solution. I think that would be ambitious for today, but certainly elements of solutions as to how you can integrate those public and private systems to work better in concert and to improve the visibility and the capability within government to oversee the operation of those systems so that as advisors to and funders of government, we're able to support that stewardship objective that I talked about. I think there's a couple of key pathways that I'm hoping the solutions today will start to shed a bit of light on. One is ensuring that if we're designing for patient centricity, making sure that patients are actually part of the data pipeline that starts to generate the information against which we design our systems, performance assess them. The other is looking at ways in which we can make the digital health infrastructure in countries an ecosystem that allows for different parties acting in different ways to cooperate and to collaborate, even though they may not be within one, if you like, monolithic or hierarchical system. That's a necessity, I think, in bringing the public and the private sector together. We won't have that command and control structure. So, on our panel today, I'm delighted to introduce Karubu Getui from Mezzanine in Kenya, who's going to be helping us with some cross-industry fertilization here. She's going to be talking to us about the agriculture sector. I'm delighted to introduce Ian Barton, who barely needs any introduction, but today he's wearing his founder of Anjani Clinics hat. Thanks, Ian, for joining. Stu Stremmel is joining us as a digital architect, and he is the facilitator as well of the Funders Forum Digital Technical Working Group, so an important guy to keep us all on track as funders. And finally, thank you for joining us, Benoit Renard, who's the CEO of TICO Africa. I'll let each of the panelists introduce a part of their, or the three panelists immediate to my left introduce part of their solution in a moment. Just in terms of the running order for today, we're going to go through each of the panelists and let them introduce. I'm going to ask Stu to make some summary comments as we get to about the halfway mark. I have some questions, which I'm going to ask the panelists, but I want you to be thinking of questions, please. I have organized the session so that we have at least sort of 10 minutes of Q&A here. It's because I'm very conscious of the fact that there's probably people in the room also working on different elements of the solution that's going to bring this mixed system together. And I want to make space for questions and comments so that we can all kind of learn from one another, make this a bit more of a discussion rather than solely a presentation. So I hope everyone's game for that. And without further ado, I'll hand over. Benoit, would you like to go first? Slide, please.
Good afternoon. Okay, wow, that's a big slide. In a few minutes, trying to explain to you what eco is. So, oops. If we can go back one slide,
Back
please.
up, please.
So we are a non-profit organization. First of all, we are a South African non-profit, even though I'm French, you can hear with my accent. We're headquartered here in Cape Town, and we are very active in East Africa, and actually Kenya is our largest country, largest market. The way we work is that from a customer perspective, from a user perspective, we are a membership. We distribute those cards to thousands of members every month in slums, in in very poor neighborhoods, in peri-urban areas, in the various countries where we work. We do this by using mobilizers who are doing demand generation and behavior change communication, enrolling those users and basically selling a behavior and selling to those users the fact that they're going to have a choice. They're going to have a choice about where they can go to access their services. And the services in our case are mainly around HIV prevention and contraception. The services are offered by a variety of public, private, and facilities and pharmacies. And those services are free. So that's the very first point. We subsidize 100% of the services we deliver to those actors. Our audience are young. They're usually below 19 years old in those various countries. One of the specificities of our system from a user perspective is that they also get loyalty points, exactly like the vitality points here in South Africa. And those points can be redeemed in any participating shops. Usually it's a small kiosk, it's a small spaza, so very informal, where users can actually buy the products that they want with those little points. That's from a user perspective. From a system perspective, what's interesting in our system is that we are supporting both community-based organizations who are powering all those networks of mobilizers. So we are actually doing some funding, but also some technical assistance to them. And from a system, health system point of view, we support the facilities through facility quality improvement plans, which are funded. So every time a service is recorded, we actually fund those plans. And we provide also some technical assistance. And that helps actually to mobilize the public facilities in particular. It also becomes actually a financing solution for them to resupply for the commodities that they have. And then overall, just a last point, we are ourselves funded more and more through outcome-based financing. And that becomes an effect, which actually means we start to be funded per performance and fund per performance all the people working with us. And we believe that there is a recipe here, maybe for the future of funding our type of interventions. Thank you.
Thanks. I'll go next. As Ed said, my name is Kerubo Getui, based out of Nairobi. Welcome to Nairobi if you're ever there.
Can we have the next slide, please?
I'll talk about vouchering. And if you can switch the slide, that would be helpful. But I'll start with introducing Mezzanine. So Mezzanine is based in the Western Cape. Our offices are in Stellenbosch, not too far away. And our work is to build fit-for-purpose digital tools using the mobile network as our enabler. So what we've been able to do is build mobile applications for both healthcare, agriculture, education, and utilities management. And what then that assists with is being able to have a pool of data that pass through the cloud can make decisions a lot faster. And so in agriculture, what we've been able to do is build an ecosystem of funders, beneficiaries, merchants, and manufacturers, if I could call it that. So I'll talk you through the process of vouchering. And basically what happens is you recruit beneficiaries and merchants. In your case, it could be a patient, it could be a clinic. In my case, it's agri-dealers and farmers. We also work with vulnerable populations, refugees, women, children, to distribute non-food items and beneficiary kits, dignity-wise, so underwear, boxers, whatever you'd like. We've done buckets, we've done COVID vaccines in South Africa. We've also done building materials. And so what happens is, I'll walk you through each of the modules we do with each of the players I've identified. So firstly, you'd have the farmers and the merchants being registered or onboarded onto the platform. And at this point, it's not a beat end all, we do registration once and that ends. No, it's an ongoing, continuous registration. And what that enables then is you're able to collect data points as you go along, and you're able to then match beneficiaries to a merchant close to them. And so what happens on the redemption is once the beneficiary is registered, they receive an SMS. And that SMS is their voucher. So it's cashless value that they then go to a merchant, our whitelisted merchant, to redeem. At that merchant point, they present that voucher. And what we've been able to do from a mezzanine perspective is two things. One, the patients or the beneficiaries in this case can pay a partial amount to receive the service. For farmers in Kenya, they pay 60%, the government pays 40%. In other cases, with Benoit's example, our funders can pay 100%. We can configure the system to respond to those needs. And what then happens also is the beneficiary can decide to redeem everything or redeem part of what they would like. And once they redeem and the payment is received by the merchant, stock balances. We have a stock management tool that then allows for the balancing of stock in and stock out. You can also order and dispatch on this system. And so giving the example of Kenya, we've been able to have manufacturers who load commodities at the port, and you can actually trace it up to the spaza. In Kenya, we call them dukas, your local kiosk where this service is being delivered. And also, lastly, we have payments. So being part of Vodacom Group, we are big on mobile money. For those who are familiar with Kenya, huge on mobile money. But we've also been able to work with various financial institutions, including banks, to be able to deliver the financial capacity that this needs. And so what you then build is truly a trust system. For example, the government of Kenya trusts that we have delivered the services, the fertilizer, because they can check the reports. You have merchants who trust the system because they receive money almost in real time for the transactions that they've had. And you have beneficiaries who know that as soon as you pay for this service, they get their commodities so that they know that their contribution in this has specific outcomes. Thank you.
Thank you.
All right, so Ez asked me to talk about Njani Clinics as a different style and a different model, because whereas the others have been talking about some form of subsidized care, in Njani Clinics we set up with two fundamental thoughts in mind. The first was, if we were going to wait till we had enough doctors to see all the patients, we'd all be dead. And the second one, so task shifting was a fundamental of it. And the second was that there was this huge cohort out there who were both willing and able to self-fund care. Classically, when we talk about creating capacity in public health systems, we talk about adding a doctor or adding a nurse or adding a clinic. Well, how about if we took away 1.5 million consults a year? How about if we brought another 500 million rand a year into the health system by creating a means by which people could self-fund their care? And so that's what we did. And we now have 220 privately owned individual nurse franchises spread across all 9 provinces in South Africa. The network is growing at just over 1 clinic per week, and we have enough funding already to do the next 60. And our target is to do 600 by 2030. Currently seeing 120,000 patients a month, every single one of them self-funded. People who've made the choice to actually go to a facility that is affordable, is accessible, and is providing them with quality care in their community, but done through nurse practitioners in order to fundamentally change the cost of delivering that service and therefore maximizing its affordability.
I go on here. All right. So when I'm the technologist of the group here, when I listen to each of them talk, and I think about when I go in to work with a public health supply chain, I start out with 4 very basic questions that I orient around. And it's very simple. It's, what do you have? What do you want? What was sent? What did you get? And then you get progressively more nuanced and sophisticated with how you answer that question. But notice I left out one really key question. And now I'm not going to pop quiz you. It's, what did it cost? Historically, in the public health supply chains, we have done a horrendous job in being able to track and articulate what are the costs, not just in the elements of what it is for the product, but what is the operational cost and what is the impact of making it difficult on our suppliers and on our medical delivery elements. We don't do that well. When I think about this hybridization, this impact of public-private connections that are happening, these experiments, all of a sudden we begin to expose some of that data. We're learning and we're pulling that trust back and forth with one another. That's a huge level of element. Those countries and places where this is successful, it is because they are working across boundaries. It's not an outsourcing effort. It's how do we share data and transactions with each other. Now, I want you to imagine for a moment that you walk outside and you go out to get a taxi cab, and you see there are 2 taxi cabs up there, and one taxi cab driver has a set of glasses on it. And the glasses do this every 10 seconds. And then the other taxi cab driver just has regular glasses, right? Which taxi cab driver are you going to choose, A or B? Oh, come on. Give me a little. Oh, thank you. Thank you. Yet, what have we done in our public health systems, in the way that we work with our data and our technology? They are sampling based. They are survey based. Our chance here in this public-private hybridization and our evolutions is about moving to these digital transactions. One of the key things about our reproductive health and maternal and child health space, and with larger evolving elements with health clinics, patient-led care starts with choice. That means, what choices are they making? How are they making them? How do I get that data? How quickly can I react to that? As we expose that, we can be more responsive. We can be more adaptable. So if you take anything out from this thing, I ask that you remember 3 things, just 3 things. And the first is, when we think about our digital efforts and these transformations that are going on, stay focused. Do only what you must, and do it well. Especially in the healthcare system. Yeah, thank you. Especially in the healthcare system, there are a litany of all great things and all great ideas and all great attributes. Yeah. Stay focused. Do only what you must. Know your processes. The second is standards drive flexibility. Now, I say this to developers and some of our techie love people, and they're like, oh, you're impinging on my creativity. Standards drive flexibility. They let you go faster. And when we go into hybridization of public-private market, we're getting more and more diversity inside of our environment, more and more diversity in our technologies. Standards is what makes it cost-effective. That's the key driver there. And we've got some people in here for standards element, and I'll give them shout-outs later. The last is generic capabilities. You're not evolving a piece of software for solving something for HIV or family planning or TB. You're making generic capabilities that are modular. And this is where we have an example from ag. It's like, oh, I can see so many ways that we could re-leverage that platform and that space inside of reproductive health and these elements. And Kenya, just so many success stories. So think about it from what are the generic capabilities, and then we can make business decisions about how we implement those Legos and how we recombine them. Don't let the technology force you into what you're choosing. All right? So I'll stop there. I think I went a little over time.
No problem. You mentioned something important that I want to build off, Stu, and that is the importance of matching together both financial information, and in public systems that would be your PFM system, together with supply chain systems. And I wonder if I could ask Benoit and Karubo to talk about the importance of including that capture of financial information as a key data element in itself, but also as an incentive. Benoit, do you have the mic? Yeah, would you like to go ahead?
So I'm going to start. A few elements there. So we can capture, so what we do is that we reimburse all the services. So we have a sense of basically how much we can inject to each of the businesses we work with, the private clinics, the pharmacies. We get a sense of how much we can inject every month. We know we put kind of a value on consumers, on patients who usually have no value. It's an adolescent girl in a slum. She's like invisible. The big manufacturers don't look at her. And in general, she's kind of forgotten. For the first time, we manage actually to take a business owner that she can represent more than 20% of their business every month. We can help them then to leverage this capacity to potentially even access credit, devices, or be in a more, in a stronger position to negotiate. And then overall, when you start to aggregate all this data, this becomes incredibly powerful, again, from a supply chain perspective, but also from a public health perspective. So sitting at the ministry in some technical working group with real data, things that are really happening in real time in their ecosystems, and that becomes incredibly valuable.
Thank you.
Thanks. I'll ask the multimedia team to put back our slide up so that we can share some funky numbers. But just to respond to your question, Ed, we've seen the power of financial inclusion significantly improve our programs. And I'll speak to two major programs that we do. As I mentioned, we work very closely with ministries of agriculture, both in Kenya and in South Africa. And one of the things that we have seen has driven the success of the project is the merchants being able to get paid in either near real time or at a set time. So for example, for the humanitarian programs with Oxfam and World Vision, the merchants get paid every week or every 2 weeks. So what that means is once money hits their account, they can then push beneficiaries to come and redeem. So we've also seen the merchant network as very powerful in mobilizing beneficiaries, where the merchants themselves call the beneficiaries and say, I have your commodities, when are you coming for them? And for the beneficiaries also, they get the choice of when they're going to transact. I think that's part of the freedom that our program gives. That, for example, if you have 14 days to redeem, you can then schedule your time. I think we also talk about the financial information as time being money, that you don't have to go somewhere and queue for endless days to receive services. And also just to look at the numbers, I mean, we've moved billions and millions of dollars in some cases, right? But it also just shows the motivator of everything that we do is financial. And I know sometimes, even in agriculture, we're like, oh, the numbers are not important. But I think the quantum of building the economy cannot be downplayed. So behind me, you see a picture of, in Kenya, we call them boda bodas, but a motorcycle rider. And just yesterday, I was thinking about how many people we've impacted through transport and supply chain on our fertilizer program. How many of these boda boda guys have made money because we were distributing fertilizer in a traceable and tangible way? And so, yeah, just to answer your question, for us, finance is everything. If the money can move through mobile money in a faster way or through banks in a faster way, the system builds trust, as I mentioned earlier, but you also have more impact faster. Thanks.
Thank you very much. Another question. All three of your programs are generating a lot of data, and you're all at the very end of the supply chain. How is that data currently being used, and what potential do you see for even greater use of that data in order to solve problems you might experience?
Okay, I'll start. So where we are using data, we're using it in three different, very specific areas. The first one is we're using retro-analysis of the aptitudes that we looked for that worked in selecting nurses, because we're trying to take nurses and turn them into people who own and run a business and who market to their community and who demand generate for their own business. So we're using lots of meta-analysis of data to look for what actually worked in that respect. And the second place we're doing that is in site selection. What are the data points? What are the data proxies that we have to look for in order to understand where to put the next clinic in order to make sure that it's successful? The third place, and the most important place, is then in the development and understanding of the competence, the capacity, and the compliance of the nurse practitioner. How compliant are they to clinical treatment guidelines? How compliant are they to formulary? How compliant are they to diagnostic guidelines in terms of their utilization of rapid diagnostic tests? So we can look at their consumption data, we can look at the diagnostic data, we can look at every single thing that they're capturing into their clinic management system, and we can see their compliance, we can see their requirement for retraining, we can see their information that has to be fed back to government, because we partner with government for vaccinations and family planning programs. And so all of that information enables us to drive the network better and better and better.
To complement what Jan was saying, in our case, we also use it for program management. So we get real-time data. Every time somebody swipes the card to access one of the services, they get a service for free. It's an information that actually informs who we should refund for what value. But that also gives us an idea of the performance of our program. And that means that if we see underperformance, we know where to retrain, we know where to focus. The second point, we are fundamentally a very fancy voucher system. It's a membership system with multiple vouchers. It's prone to fraud, and I'd be interested to know how you fight against it. In our case, that's how we use data. You know, you see spikes suddenly, and again, real time becomes critical here. You can't see them 3 months later, otherwise you would lose a lot of money. You see spikes, you see abnormalities, you see behaviors that start to be a little bit, again, a bit unusual. That's where you intervene, that's where you send your auditors, that's where you potentially even pull the plug before you do an investigation. That's where AI becomes so important, because everything I just described could be done by a human brain, but it's much better if the machine does it. In an aggregated kind of way, we use our data to handle our relationship with our stakeholders, the government in particular. All the data we are busy getting in the public sector is gold. I mean, we are dealing with the Department of Health in the Gauteng province in our program in South Africa. And I mean, we are bringing data that is so valuable. It can inform policies, it can inform, again, refocus, and eventually could actually inform resupply.
Thanks. And just to add on to what my colleagues have said, in terms of data, I believe data is what drives the success of our programs. And I'll talk about it in various ways. So first is the data points we collect when we start programs actually determine our reporting. So for example, I mean, being a woman and being, you know, an advocate of gender balance is, can we report on the genders that have received services? What age groups? So that's the first thing we do. I think more importantly for the ecosystem partners within our space is the president himself in Kenya can access our dashboards and see where stock is and where stock is not. The manufacturers can access data and say, we are depleting stock in one section of the country and it needs to move to another section. Politically, members of parliament and governors can call and, you know, raise hell at Ministry of Agriculture, but the person in charge of the program can log in and say, why are you raising hell? There's fertilizer in your section of the world, right? And so we've seen the ability to make real-time decisions on how stock moves within our system. Also, in terms of the redemption rates, some of our programs have 100% redemption, which was unheard of at some point. But it's also traceability to say, how successful have we been in this program? Is it 80% of the people who are supposed to come? Is it 30%? Is it 100%? What does success mean to us? Is it how much money has gone through the ecosystem? Is it how many bags have been circulated? What does success mean to you? And lastly, I think we've also seen beneficiary behavior. How quickly do people respond to the call to redeem? And how long do they get to redeem? And so what I'll also say in terms of the data points, we keep learning. I've done this program now 6 years. It's been around 8 years. Every year we make an iteration, sometimes every 6 months. And that means the data that we're collecting actually changes our behavior towards all the stakeholders within the ecosystem. Which partners do we have on board? For example, we have railway companies, we have the shippers, we have transport, like road transport. All the decisions that we derive here affect how commodities move within the ecosystem. Thanks.
Thank you very much. So thanks very much for giving us an idea of these solutions. I think it represents a great spread and some really innovative practice. I'm going to open it up. We've only got about 7 minutes left, so I'm going to open it up right now for Q&A, as I promised we would do that at the start. So if we could get the roving mics going, that'd be great. And who would like to go first?
Be brave. Be brave.
So I'm actually from Mezzanine, full disclosure, from the health side of the business. I think one of the things that I've found particularly interesting and challenging over the last few years is figuring out, like, there's all this data, yes, and we're all sitting on it and we've all got our own little universes where it's happening. But as soon as we have to start working across sectors or across programs, so Karibo's farmers are also the people who have to now go to probably, Benoit, your clinics at some point in the same regions, but we have no way of communicating across programs. And I know it's like a million miles away, but just to kind of take a step back, and even within a business, we have firewalls, obviously, between the different programs, and we have no mechanism for sharing across programs sometimes. So I think we really wanted to speak about the agriculture use case because it's so similar and the building blocks are the same behind the scenes. It's people getting commodities in places, consuming things, and usually it's the same people who also need to have access to public health, or FMCG goods, whatever is required. So when a person shows up in the last mile, how do we start bridging between some of these systems so that we know what their behavior is? Yeah, I guess that, how do we do that? Million miles down the line, maybe.
Thank you. Would anyone like to put their hand up to answer the question there?
Oh boy, I guess that comes to me. So the first answer is data standards. Data standards, data standards. It all starts with your master data. And right now we have a high friction environment. And it takes a massive amount of energy to be able to link data from one vertical to another vertical. And I think some of the power of what we've heard here is where they're combining like this public-private or private-to-public on the finance vector. But it's still the same person. It's still the same person. And when we think of it from a health outcomes perspective, it's still the same person. And I go back to what Ed was saying at the beginning about going to patient-centric care, going from the bottom up instead. The challenge here, beyond the interoperability platform, beyond the operational cost to make sure that you can make that low friction and adhering to the standards, is what is your data sharing principles? How do you go about aggregating and making the data safe to work with? This is a fundamental challenge in this whole context for all of us. And so in our private model, how do we have co-competitors operating in the same space, but we collaborate together to achieve a health outcome? That's the magic. Data sharing is what makes that safe to happen. And there are ways to do it. Safe harbor is the key place to start from, and I'll stop there and open up to others before I get too off task.
Thank you very much. Any other questions from the room? No? Okay, so I have another question, which is, Benoit, in your solution, I believe you started working predominantly with the private sector and have been able to bridge your solution across to work with the public sector. Karubo, you almost worked in the opposite way. We've got a few minutes left. I wonder if you could just talk to us about that journey and how you manage that integration.
I mean, it was definitely a journey. I mean, the first times we tried to work in the public sector, our system seemed either competing with an existing system or almost irrelevant. You know, there's no subsidy, services are free. Anyway, our job is to service all those users, those patients. You know, data is a secondary aspect. We got in really through the idea of incentivizing the use of data and the generation of data. So giving a few loyalty points to the users themselves, to the nurses, you know, helping them to figure out how to use it, not adding another device, simplifying the system. Our apps are incredibly simple, a bit too simple to even demonstrate. You know, you would find them boring, but you know, it's 3 clicks away from just entering the data. It's a scan. That's how we got them in. And then ultimately, this idea of actually creating this fund, which they can use the way they want. They can use it for an end-of-the-year party, or they can use it to fix the roof, became actually a real incentive. It empowered the clinics. It worked very well in the Kenyan system. We're trying to adapt it to the South African context, and I think the insights are going to be different here.
No, thanks, Benoit. And just to add on to his point, in terms of public-private collaboration, just for an example, so in Kenya, for us, especially in the agriculture space, we just look at merchants as merchants, whether it's a public National Cereals and Produce Board, who's an aggregator of cereals, or it's an agro dealer, who's a private merchant. So we've seen that, I think for us, it's simplifying the process and understanding the process as it is. But I think the work I do as mezzanine is also a lot of building blocks. So for example, the building blocks that I did in Kenya is what Dale used, for example, when we were doing the COVID vaccine program in South Africa. And it's basically just learning from what we've done and seeing the public-private space more as we can't do this alone, right? There has to be stakeholder merging, that the lessons that we've learned from the private sector can be used in the public sector and vice versa. And so I think for me, one of the things that I'm interested in pursuing, for example, with reproductive and child health, is once the mothers have left the clinic, how do we incentivize them to come back to vaccinate their kids? Can we use vouchering for that? That's a conversation I'm having. But I think it just goes to show that it doesn't matter the commodity, it doesn't matter the merchant, It's just how can we make this entire system accessible to everyone at a point of their convenience.
The future of data management for us in Unjani is about being able to understand, quantify the assumption and management of risk. In a private sector environment, and even in some of the funded models, we have to somehow move from fee-for-service, the pay-to-engage model of current healthcare systems, into capitated systems, because that's where national health insurance systems have to go. And we're seeing many national health insurance systems across the continent really, really struggle because they've tried to build national health insurance systems that are fee-for-service based. And so they're paying every time a practitioner sees a patient, rather than moving to a capitated model, which is all the successful models that we see in other parts of the world. The movement from fee-for-service to capitation demands massive quantities of quality data that you're able to analyze to a level where you're able to understand what your network is going to assume as risk and how it's going to manage that risk and still make margin.
I want to...
Stu, we're over time, so you just need to wrap in a minute, please. Go ahead.
Yeah. It's a move from risk mitigation strategies to risk sharing strategies. That's the power of a public-private partnership, is where you can spread risk in interesting and innovative ways that the private sector can't do on its own. This is a really key point on the things. Thank you.
Thank you to all the panelists. I want to do a quick sum up as well, which is I think what I've been trying to, the reason why I invited these panelists together today was because I feel like I'm excited by and I see real potential for, as Stu said, changing the paradigm through which we capture data. And I think that by doing that in a way that captures transactions, including that financial part, it aligns incentives, and it means that by aggregating transactions, we can get the insights we want without having to spend money on this very expensive sampling methodology, which is also fraught with risks and doesn't do some of the risk balancing that you mentioned. It doesn't support an ecosystem. Thank you to all the panelists. Thank you for being here this afternoon, and please give them a round of applause.
Please remember to let us know what you think about the session you have just attended. Complete the feedback on the app.